morning. It's Dr. John Bennett broadcasting from Miami Beach. We have the pleasure of having another UHA Neurosurgery Grand Rounds with Giuseppe Lanzino, a second presentation. And I'll let UHA introduce him. Welcome, UHA.
Thank you. Giuseppe made 1 week ago excellent presentation on dural AV fistulas, and now we speak about cerebral AVM. So I repeat the short introduction here. I don't think so much has changed in 1 week, maybe 1 or 2 publications more by him, but it's okay now?
Yes,
Can you see?
it's good. Yes,
okay.
good.
Yeah.
Okay. This is Giuseppe Lanzino. He's like 1 week ago I told, he's one of the most creative, productive, and critical hybrid cerebrovascular neurosurgeons in the world. He works as a professor at Mayo Clinic, Rochester, Minnesota, and has long time experience. So he has more than 500 high-level publications. Maybe during the 1 week, as I mentioned, 1 or 2 came more. He's excellent in writing, giving speeches, giving lectures, but also in treating patients. We have been friends since 20 years after his first visit in Helsinki, and we have had bilateral visiting, and he has been here also in Henan Provincial People's Hospital, where I nowadays work, visiting when I began my 3 years working here. So this is just as a few examples what we are doing here in our hospital, in my hospital, this Henan Provincial People's Hospital, Zhengzhou. There's increasing numbers of cerebrovascular cases a year, aneurysms more than 1,100, AVMs more than 100, and dural AV fistulas more than 50 cases. Of course, in a big country, everywhere in the world, the admission policies are different and biased, and here are also university hospital is even bigger than the Henan Provincial People's Hospital. Actually, the largest hospital in the world at the Henan Provincial People's Hospital is the second largest hospital. This depends on the big population here. So you don't know what is the actual situation. You get the patients and they are selected according to the skills of the doctors. So nowadays, increasing numbers of cerebral AVMs are diagnosed and treated. And there are these treatment modalities are microsurgery, endovascular treatment, irradiation, or combined. Here in my hospital, there are extremely extensive experience in endovascular treatment, and the Chinese patients prefer a lot endovascular treatment. So in my center, Dr. Xu and Bai are extremely skillful and can occlude a high number of these cases by endovascular means. Unfortunately, to publish the series in China is not so easy because of the language difficulties, and this is a pity because many neurosurgeons, endovascular surgeons have extensive experience. It is important to follow up the patients well, and this is one of the drawbacks in China. It might improve, but it's difficult. So I speak shortly about my personal experience. I have done more than 600 AVMs, mainly in Finland. First case more than 40 years ago, and I have used mainly microneurosurgery in all the cases, later combined with endovascular treatment. Finland is a very special country because you can follow up all the patients 100%, and this is extremely important. And we have published on the natural cause of the AVMs in a series followed up since Second World War. So this is one of my first cases, this number 4 or 5 in my series of those more than 600 AVMs. This is 1982, close to 40 years ago. I was young neurosurgeon, had read my books, seen some giants to operate on, so I was bold and strong enough to take this AVM out successfully. Even now, it would look extremely demanding for me, and it was done without any embolization, so it was only microsurgical extirpation, total extirpation. It was the dominant temporal lobe of the patient because he had only one hand. So this is nowadays, this is from yesterday, this case. 21 years old male, university student, was in coma 8 months ago, had a large AVM parietal, left side, it was 3 times embolized, and this is after the 3rd embolization. You see there's a lot of onyx material in a close to 6 centimeter, I would say 5 centimeter large AVM. I didn't measure, but it is close to the upper limit. So, but what could not be embolized was the lower part, and even it was tried, it could not be occluded totally. So it was decided to do microsurgery for the rest. And looking at the pictures, because it is parietal, it is of course difficult, but you see also that there are very high flow in the veins. So it was operated on yesterday. These are post-operative pictures. Onyx cast was removed, and it was really high flow. Even many people would say that 80% of the AVM were occluded, but it was difficult operation. My teacher, late Professor Charlie Drake, said after difficult operations, what a fight, and it was really big fight. And high flow, difficult AVMs, you have to fight. You should never give up. I'm a country boy. We used to throw cats on the wall, and they stick on the wall. They don't fall down, and you should be like that when you are doing open microsurgery and demanding AVMs. And the heaviest bleeding are at the end of the operations, and they stop only with special skills and endurance. That's why you should not even begin AVM operation if you are not 110% sure that you can take it out. What I'm doing in the last moments, you are tired. After 3 hours operating, you are tired because you have to do as fast, and I try to do as fast as I can. But in the last moments, the heaviest bleeding are coming, and then I'm swearing in my mind or loud, and in these last moments, I know we are finishing the operation, but I begin to hate everybody in the operation room until the AVM is out and the bleeding stops. And then you have to make good hemostasis and good postoperative care. These are my final words here. It's important to have extremely good follow-up of these AVM patients. You should never trust on your treatment results in long term, especially in young patients, children. And you have to remember that partially occluded AVMs have 3 times higher rebleeding rate than without any treatment. This is our Helsinki, Finland, Finnish follow-up studies. Now I give the words to Professor Lancino. We will hear certainly a very good lecture. Thank you very much and welcome.
Thank you for the introduction and for the invitation. And this is AVM is really a topic that has fascinated neurosurgeons for many, many years, and we all know why. What I'll try to do, I will try to review the role of each therapeutic modality. And then since we have many young colleagues, then I will share some practical tips and tricks of AVM surgery that I learned from my teachers, and over the years I've become to appreciate certain things that were said, and I could not appreciate them much when I was younger and without a lot of experience. So again, we discussed last week in dural fistula, we have many therapeutic options: observation, embolization, radiosurgery, and microsurgery. And when you have different options, it's great because you can apply the best option to the individual case. But at the same time, when there are too many options, we have to be careful, because sometimes we tend to apply one option over the other based on a lot of considerations that don't necessarily at times reflect the best patient interest. We also need to think and realize that each therapeutic options has risks and downsides. And when you start treating an AVM, it's very important to have a definite plan. As Professor Ernestiemi mentioned, partially treated AVMs have a risk of bleeding that is 3 times higher than AVMs that have not been treated at all. And there is no question that there is a widespread use of what are called so less invasive techniques that it's often not always justified. So when we think about AVMs, what are the factors that affect our decision-making process? Well, we know that the natural history, and the natural history is often related to intertwined with the clinical presentation. We look at the complexity of the AVMs, that it's important particularly because of the potential risk of treatment. Patient age is a very important factor. Younger people have a much longer life expectancy and therefore are exposed to a higher overall risk of bleeding. And also younger people tend to recover better from surgery in particular. And also the response, for example, to radiosurgery is highly influenced by age, with the younger people often having a dramatic, rapid response to radiosurgery as well. And there is no question that it's important to keep patient preference. Of course, it's very important, but patient preference, it's important once patients have been informed objectively and honestly about the pros and cons of each therapeutic modality. The topic of AVMs, as we will see, it's really closely related to the history of our specialty and closely related to the giants. Professor Ernestiemi has made, and this team have made seminal contributions to our understanding of AVMs and selection of best therapeutic modalities. This is the Helsinki landmark natural history study that really guides our decision making, especially as it applies to unruptured AVMs. This is from a publication that was a few years ago from the Columbia group. And what we know that, of course, as I said, the clinical presentation, particularly hemorrhagic presentation, and some of the characteristics of the AVMs, in particular the presence of deep drainage, seems to be strongly associated with the risk of bleeding. And therefore, as I said, these are some of the factors that we consider when we try to decide what to do in the individual patients. Now, surgery is for AVMs, I think, is still a very important and one of the primary therapeutic options. Why? Well, because it immediately removes the risk of hemorrhage, which is often the main reason why we treat an arteriovenous malformation. But as we know, especially in complex arteriovenous malformations, it's invasive and is also associated with a certain degree of morbidity. Now, there are some cases that are fairly straightforward. This is a young girl that presented with headache and lethargy from this posterior fossa bleeding that was related to an AVM. This was a relatively straightforward case and was treated with surgery. No embolization was done here because, again, didn't feel that it was necessary. And as I mentioned, every therapeutic modality has its own risk, so no need to add something that could have made the surgery faster, a little bit easier, but definitely, at least in this case, it was not necessary. So when I think about surgery, we prefer surgery in patients who have had who have presented with recently ruptured AVMs that are accessible, because, as I said, the surgery is the therapeutic modality that immediately removes the risk of bleeding. And in unruptured AVMs, we would consider surgery if we feel that the surgical risk is low enough, that is way lower than the natural history itself. Then there are some particular cases. This is an unruptured AVM, but these patients start having seizure. And what you see, there is a venous varix that is associated with edema. There is no evidence clinically or radiologically of bleeding, but this is a symptomatic AVM. The varix, especially with the associated edema, it's definitely worrisome. It's in a fairly accessible area, and this is another AVM that I think it's a pretty straightforward decision to go ahead with surgery. Now, I am a strong proponent of endovascular therapy for aneurysms from dural arteriovenous fistulas. I am very, very cautious with the embolizations of AVMs. There is no question that embolization of AVMs has a very important role, and I will show some examples where embolization is very helpful, but I am a little bit skeptical about the use of embolization as a curative modality to try to kill the AVM, because I have seen that is associated with some degree of randomness, and there is a random, you take a chance when you try to close an AVM completely, and I think that we have to be very careful, and we have to carefully analyze pros and cons when we try to use embolization or propose embolization as a cure for the AVM. But there is no question, as I said, that the embolization has a critical role in several other situations. For example, to treat so-called dangerous portion of the AVM in a patient who has had a rupture, like this 70-year-old lady has a history of dementia, presented with mostly subarachnoid hemorrhage. She has this deep AVM, but the hemorrhage was from these dysplastic pseudoaneurysms around the course of the superior cerebellar artery. And in this case, you can see what was done was to embolize the feeding vessel carrying those dysplastic aneurysms, with the idea of taking away the source of hemorrhage, and in this patient, reducing the risk of bleeding. Given her age, given her underlying condition, she had a history of dementia. No attempt was made to treat the underlying AVM. You can see here the follow-up CT scan with the glucose, and this patient, once she recovered from the subarachnoid hemorrhage, was discharged home. Then there are situations where almost you deal with impossible AVMs. This is a 16-year-old, and we treated this young lady years ago. She presented with severe headache and coma. She underwent placement of an external ventricular drain, and she recovered. And you can see on the CTA there is this monstrous AVMs that pretty much takes her entire brainstem, but she is, once she recovers from the coma from the intraventricular hemorrhage, she's almost intact. She has just some foot weakness. So what we did in this case, you can see this was most likely the pseudoaneurysm, the site of bleeding. And we targeted the feeder carrying this nidal aneurysm, and you can see here that was embolized, but the bulk of the AVM was left alone. I don't think that in this case there are reasonable other alternatives to try to completely eradicate the AVM. And she's stable now 7 years later with the mild foot drop. And what we do, she comes and we check her MRA to make sure she's not developing new areas that might require additional treatment because of increased risk of bleeding. Embolization has also a role in complex, but not in every AVMs, to decrease the blood supply in preparation for surgery. This is a rather large cerebellar AVM that patient that presented with a headache, no history of bleeding. And what you can see on the right is that we did a embolization with the goal of selectively taking some of the feeders, and we chose the feeders that were both safe and also those that were a little bit deeper from a surgical perspective. And you can see that the AVM was partially devascularized, and then the patient underwent surgery. And here you can see some of the coils that were used to um, close some of the feeders in preparation for definitive surgery. This was a fairly safe embolization because the proximal feeders were targeted. We stay away from the nidus, we stay away from any vein, and therefore we achieved the goals of preparing the the brain for the removal of the AVM, trying to minimize primarily the potential effects related to sudden removal of such a high flow AVM. Embolization can be, we always say, well, embolization is indicated to remove or to embolize some of the feeders that are difficult to reach with surgery. And that, of course, it's great when can be done. And its problem is that it's not like cannot be done. No, it can be done, but often these feeders, which are often deep perforators, they are also the ones that are at higher risk of complications from embolization. This is a patient, this is an interesting case because you can see she had an MRI in 2007 for unrelated reasons and was absolutely clean. And then in 2011, 4 years later, she presented with a small hemorrhage, and she had developed this rather large AVM. We now know that AVMs are not congenital, but tend to form during life. In this case, the role of embolization was to try to take some of these feeders from the posterior cerebral artery that are diffuse and at the bottom of the AVM that was eventually resected. In this case, a patient we knew that she had a high risk of a visual field cut from the resection. So we felt that the risk of the embolization was worthwhile. And this is her follow-up angiogram. And this, you can see, this is the visual fields were fairly normal before surgery. After surgery, she had a inferior quadrant anopsia. Now, embolization is used a lot with this concept to reduce the volume of the nidus before radiosurgery. We have here at Mayo a very active radiosurgery program, especially for AVMs, but we really don't buy into this concept. And if you look at the literature, and this was one of the largest series, really the literature, it's fairly controversial regarding this topic. And I would say that really does not support the fact that embolization to reduce the volume of the nidus is beneficial in increasing the efficacy of stereotactic radiosurgery. And therefore, although this is widely applied, this concept around the world, it is not something that we believe and we don't practice. And then, as I said, there has been particularly with liquid embolic agents and more recently onyx and similar materials that you can inject for a long period of time over several sessions. And more recently, the concept of retrograde transvenous embolization in order to get a better penetration of the nidus. There has been a big impetus over the past 20 years to try to treat AVMs with embolization. And again, it's possible. It's definitely several groups have demonstrated that it's possible. But the issue is that, as I said before, is that there is some degree of a random risk that you take, because especially as you try to fill the last portion of the AVM where you have already compromised the vein, there is a risk that the AVM can bleed, and we all have seen several cases. And that's, as I said, that there is this random factor that makes me uncomfortable, except in a very selected case, to consider embolization for cure. This was one of the earlier largest series from Turkey. And you can see that even in their hands, about 50% of the AVMs were completely obliterated. And yet the permanent morbidity and mortality was not insignificant. So it's a concept that I personally don't subscribe, and I would be very cautious, except in very selected cases. There is no question that radiosurgery has a very important role in the modern management of AVMs, particularly for small AVMs in eloquent areas. We are doing more and more staged radiosurgery, especially in young patients with the large AVMs, and this is a very reasonable and promising approach. And I think keeping in mind the patient preference, it's a reasonable option in small AVMs that could otherwise also be treated with surgical resection if the patient prefers radiosurgery. This is one of those cases that we have treated with the staged gamma knife, and 43-year-old man presented with intractable headaches, a rather diffuse parieto-occipital arteriovenous malformation that was treated effectively with gamma knife, and this is the 6-year follow-up in this patient. A few words about when you talk about AVM, you cannot ignore the Aruba study. We're all familiar about the study, so I will not go into the details. The investigators have now published a longer-term follow-up. My reflections on the Aruba, I think that it has really not changed the way I practice, because I always try to treat those AVMs where I felt that the natural history was worrisome, and I would treat if I felt that the risks of treatment, no matter what type of treatment or what combination, was low enough to potentially benefit that patient. I think that the Aruba has had a positive impact in a way, because it has made, like the issue in the late 90s for unruptured aneurysms, Aruba has made us much more careful about the complications of our treatment, and has also taught us, once again, I would say not taught us, but to remind us that it's very important to be honest about the shortcomings and the potential risks of different techniques. Now, as I said, in this second part, I will discuss some fairly basic principles of AVM surgery. And this is a compilation of things that I've learned from my mentors and teachers, from reading, and then from operating on close now to 200 AVMs myself. And I'm doing this with the younger colleague in mind, because, as I said, a lot of these things that I will say, I would hear from my mentors, but they were said in single sentences. And as I did not have a lot of experience, I was unable to really appreciate the depth and the importance of what was being said or what I was reading. As Professor Ernest Niemi said, really, AVMs, it's about psychology. You need to be ready for a fight. You need to be able to and have a careful planning and the strategy, not only in the type and combination of different treatments, but also in your surgical conduct. And then you need to execute. And a lot of these considerations that I will make, they apply primarily to more complex AVMs. There is no question there are some small, relatively simple AVMs that some of these concepts don't necessarily apply. So when you are attacking a complex AVMs, you must be ready for that day. You must be ready for a fight. And as it was mentioned before, Professor Drake used to say, AVMs are nothing but a lot of hard work. And there are some very simple concepts that I think are very important to keep in mind. There is a lot of stress nowadays on less invasiveness and small incisions and small craniotomies. But when you are dealing with an AVMs, like for large meningiomas, large craniotomy is key. You really need to expose not only the visible AVM, but you need to have a panoramic view of not only the main draining veins, but also of the secondary draining veins, because those are the ones that where you might end up with a very small residual shunt. Now, it's for those AVMs that comes to the surface, it's also critical to have a full visualization. This is a cerebellar AVM, full visualization of the subarachnoid portion of the AVM. It is very important, you know, for a perfect execution of AVM surgery, we rely on a clean field. And there is nothing worse than getting a subarachnoid hemorrhage from not so careful opening of the dura. So it's important to open the dura under the microscope. And there are often some adhesions, particularly of some of the draining veins, or like you will see in this case, they can be very small dural feeders that might actually go directly into one of the draining veins. So that's a fairly simple, basic, but very important principle. You have to be extremely careful, because otherwise, if you are not careful, then you end up with the subarachnoid hemorrhage from the very beginning, and then will obscure your subarachnoid planes. ICG fluorescence is very useful during AVM surgery. At the beginning, even for the expert surgeon, might not be so immediately clear what is a feeder in a complex AVM, what is a feeder, what is a draining vein. So it's nice to have that feedback with ICG fluorescing at the beginning so that you can easily distinguish the feeders from the draining veins. And it's again, it's not absolutely necessary, but if available, it's nice to have that confirmation and that feedback from the intraoperative study. Now, everything about AVMs is in Professor Yassergill's book, and you can see that the classic description is of a conic shape, often with the apex in toward or inside the ventricle. Now, this is at least for the AVMs that I operate, this superficial component. This is not that common for complex AVMs. The more common ones that I see are AVMs that are inside a sulcus, and then like an iceberg, they are hidden underneath and covered by white matter. And I think this is one of the most difficult parts of the AVM resection, especially in eloquent area, where you try to find that sweet spot between the boundaries of the nidus. And remember, the nidus is usually not so linear, but the nidus, it's like small grapes that protrude into the white matter. And it's for complex AVM, it's relatively easy to get outside the bound, inside the nidus, which can be a very bad mistake, especially in the early phases of the resection, as you try to spare as much as possible some of the eloquent area. So that has been one of the most difficult parts of the resection for me, is to really understand that the nidus is often buried underneath the white matter, and it's not nice and linear, but there are small portions of nidus that protrude into the white matter, and to follow that and to stay carefully and follow that plane is definitely one of the most challenging parts of AVM surgery. So because of this, it's very important at the beginning of the surgery to spend really a lot of time to open as much as possible the sulci around the AVM, so that you can unfold and get better exposure. And as you follow down into the sulci, then you can get better control of all the feeding vessels. So it's extremely important to spend enough time in this part without rushing immediately in trying to go around the AVM. Now, this portion of the dissection might seem terrifying at first, but actually the veins are, the draining veins are arterialized, so, and the arachnoid around the AVM is thickened, so that in a way protects you during this part of the dissection. This part of the dissection, where you carefully apply microsurgical techniques and nicely dissect the subarachnoid planes going down in the sulci, I found it also very psychologically rewarding, in the sense that as you do that part, you start feeling good about yourself. The operation looks beautiful, and you start thinking you are the best surgeon in the world. So it puts you in a positive psychological state. And this has been really well defined by Michael Lawton in his book, is the calm before the clash. Because for complex AVMs, as I said, at the beginning of the resection, everything looks beautiful, and you start getting this feeling. You start thinking, wow, I'm the best neurosurgeon in the world. But often toward the end of the resection, the feeling is gone, and you might be facing something like this. That is definitely not something that you want to show in a conference, but this is the reality in few cases, especially when you are dealing with very complex lesions. Now, as I said, a lot of AVM surgery is about psychology. When I first started, I was one of my first AVMs. I really got into some bleeding that, especially under the microscope, even small bleedings, they look torrential, they look very difficult. And I called my chairman at that time, Dr. Elwood, who had a lot of experience, and he came in. He didn't scrub, but he just said, don't worry. He said, you just keep working. He said, when you're doing surgery for complex AVMs, you need to understand that you will be faced with the bleeding that at first you feel you might not be able to control, but then remind yourself you have done it before, and usually you are always able to control. And those words have helped me so much over the years, because when I'm doing an AVM surgery and there is some bleeding and you're trying to stop the bleeding and you are not successful at first, now I know eventually I will be able to control that bleeding. So it's important when you are faced with that bleeding, and just remember you've done it before, and usually you'll be able to control it. Now, I said before that the dissection of the actual nidus, where it goes deeper into the white matter, it's one of the most critical portions of AVM surgery. And I think that's the reason why it's extremely important to be very careful and to just take your time when you do AVM surgery. And you will see here what this is the AVM, and as you start going around the nidus, you can see how the nidus, parts of the nidus are really bare underneath the white matter, and you have to be really carefully dissect that plane and stay outside of the nidus. And as I said, it's a very difficult balance, because you don't want to compromise any of the brain, but at the same time, entering the nidus can be a really bad mistake. Deep feeders is one of the trickiest part of AVM surgery, especially in the complex lesions. Also because they usually you are dealing with this toward the end of your resection. Even there are a few practical tricks. First of all, it's important to isolate in other you want to that feeder starts bleeding, and it retracts into the normal brain, or worse, into the ventricle, and then you end up with the hidden hemorrhage and brain swelling, and that, of course, it's a major problem. The other thing to understand is that the deep feeders, they have abnormal walls, so they don't respond to normal coagulation. I will show some examples. But they respond better under flow arrest. One of the most effective ways to deal with this is what Professor Ernestiemi over the years has popularized and defined as dirty coagulation. In other words, to take a little bit of surrounding white matter within your bipolar cautery, so that the bipolar blades are not only around the small deep feeder. So this is this problem, and you can see, so you isolate the feeder, you make sure that you have an adequate length. Then you try to coagulate, but you will see what happens. You coagulate, and nothing happens because they have abnormal walls, and their abnormal walls don't respond to coagulation. As I mentioned before, they respond better though if in conditions of flow arrest. So one of the tricks is to use one of these mini clips that was designed by Dr. Sant here at the Mayo Clinic, specifically for AVM surgery. Once you have created a situation of flow alert, then you see, like here, there is a flow arrest. You will see that eventually that feeder responds better to the. I rarely use these Microclips, only when needed toward the end of this, like in this case, because I don't like to have a field with too many Microclips around. Another little trick in this situation, as I said, always make sure that you have enough length. But after you have coagulated the feeder and it looks it is well coagulated, instead of when you go to resect, to cut the coagulated vessel, instead of cutting all the way across, you just cut a small portion so that if there is any bleeding, and you will see here in this case, if there is any bleeding, you have still the two ends attached, so they won't retract, and you can finish your coagulation. Again, it's very, very important. You see here, don't cut all the way across, leave a little bit of connection so the two ends are still together, and if there is any bleeding, then you can see here the dirty coagulation, taking a little bit of white matter around to it's you know, a very effective trick in this situation. The as I was preparing for this, I had in mind particularly the young colleague, because as I was reading Professor Yasek's book, there is it's just a sentence, is something along the lines that the secret of AVM surgery is in the ventricle. And at that time, I didn't understand exactly what he meant, but basically, I think what he meant is that for complex AVMs, there is almost always a small AV shunt down in the ventricle. And if you get to the ventricle, it's somehow much easier to control those deep feeders in the ventricle than in the white matter. And also there is almost always a small ependymal, deep ependymal vein that you might not appreciate as a deep drainage on the angiogram. And this is a case in this is a patient with the complex frontal AVM that was removed, and there was really on the angiogram not a good hint of any deep involvement. And this is the post-operative angiogram. Everything looks good, but if we look carefully on the AP, you see that there is a small residual nidus that goes then into this deep draining vein, and you can see better here. And then this patient required a reoperation. And actually on the post-operative MRI, you can also see at the depth of the surgical cavity that there is early filling of this ependymal, this deep vein. So the ventricle definitely, and nowadays on the T2 MRI, you can tell if there are vessels that go toward the ventricle. Then it's much easier to control those deep feeders once you have entered the ventricle, rather than chasing them in the white matter. There are situations, and very few surgeons talk about this, but as you are resecting a large AVM, and it's been a long operation and you have disconnected most of it, then it's possible that even though if you have not touched and the main draining vein is still connected, but you have slowed down the flow to the point that the actual AVM might thrombose, and the AVM consistency changes, and the AVM becomes much more difficult. It's full, and it's much more difficult to retract. So situation, if that happens, then you need to go fast and finish your resection. The other thing is also, if you're doing AVM surgery and all of a sudden the consistency of the brain changes, you notice over a course of a few seconds or minutes some significant brain swelling. That's often related to a deep hematoma that is or either on the boundaries of the surgical resection, or worse, in the ventricle. And in such situation, if there is any question, the intraoperative ultrasound can be helpful in recognizing this problem. As I said before, the history of AVM surgery is closely connected to the giants that have shaped our specialty. I remember my dear friend Evandro de Oliveira always says, like a big meningiomas, at one point you get the sense that the AVM has surrendered. And yes, there is, as you're working on a complex AVM, you get to that stage where you finally feel, okay, now I got this. And but be careful, because there are still some hidden pitfalls. And a common one is that there is almost always a direct feeder going underneath the draining vein. And you can see here, large AVM, I thought they had disconnected everything, put a temporary clip on the draining vein, but the draining vein is still arterialized. And the reason is that there are these deep feeders that are right underneath the belly of the vein. What I've learned is that it's important, as much as possible, whenever possible, really to skeletonize concentrically the draining vein so that you can take care of these feeders. And this is something that is particularly important in children, because in children there is this, it's been defined as a linear type AVM, where there are small AV shunts directly into the trunk of the main draining vein. And in those situations, it's important to really circumferentially skeletonize the draining vein to make sure that there are no direct AV shunts. Nowadays, that can be easily recognized with ICG fluorescent at the end of your resection. If there is, that's one of the reasons why, as I mentioned before, it's important to have a craniotomy large enough that you have a good visualization of not only the main draining vein for a certain length, but also secondary surrounding veins. They can be the site of persistent small deeper shunts. And this concludes my digression on AVMs. Once again, I'd like to thank Professor Ernest Niemi and the team in China for the kind invitation, and Dr. Bennett for giving me the chance to share over these past 2 weeks, some of the things that I've learned over the years. Thank you very much.
Okay, very good. Okay, Juha, you want to lead? Thank you very much, Dr. Lanzino. Do you want to lead the discussion, Juha?
Okay. Okay, thank you very much, Giuseppe. Actually, everything what is experienced in the open microneurosurgery, difficulties and the tricks were mentioned. There I don't have much to add. There are some questions, the audience.
Okay. Okay. Verdab, how you doing, Verdab? Do you have any questions?
There is a question in the panel.
Okay, I'm sorry, I missed that. Okay.
This is from Yuhun Liao. Can someone explain arrest flow for deep feeders?
Sure. What I meant is that you know, these deep feeders, they don't respond very well to the usual coagulation techniques because their wall is abnormal. But if you arrest the flow into the feeders, like I showed with the microclip, then it is easier to coagulate because there is no flowing blood inside the feeder. That's one of the tricks. The other tricks, as I mentioned, is, and that's very effective, as Professor Nesniemi, instead of putting the blades of the bipolar right against the walls of the deep feeder, to take a little bit of white matter so that you have some white matter in between the bipolar blades and the feeder. And that's another technique that allows you usually to coagulate and control these feeders. But it's much easier to control if after the flow has been slowed down, rather than if there is active flow. Some surgeons more recently have also proposed, you know, the AVM, it's an AV shunt. It's a low pressure shunt. And what it does is basically sucking blood from all the feeders. So the idea that some surgeons are proposing is that if you go down to the deep feeder after you have disconnected the main ones, then you, in a way, you are increasing the flow from the deep feeders. So if you go down to the bottom of the AVM before you have disconnected the larger feeders, might be easier to control the deep feeders, because the flow is prominently from the larger ones, and therefore the small deep feeders, they have less flow than they might have if you disconnect all the superficial larger feeder.
Okay, very good. I'm glad to see Dr.
Thank you, Professor. Thank you.
Okay, great.
Have you ever tried adenosine? Adenosine stops the heart for 30 to 60 seconds, so it might be. I have never tried in AVMs, but used a lot in Helsinki in others, maybe 200 cases. But it came in my mind, it might be also a good trick.
Yeah, I think there is there is a situation that likely it's not common, but it happens, is that you are working and you are close to finishing, and then everything bleeds. And in that situation, sometimes the best thing to do is just to go fast around and remove what's left, and then the bleeding is controllable. I think if in that situation of extremis, it might be a reasonable thing to do. But unlike aneurysm surgery, the adenosine for AVM surgery gives you just few seconds, but it might be useful in that situation. That again, it's a situation we all have been at some point, where everything bleeds and you know that the only option is just to quickly go around and take out, and then so that might be reasonable.
Reda, please go ahead.
Yes. Thank you, Professor Lanzino, for this spectacular presentation of this challenging topic. Always amazing. My question, do you mean actually, doctor, that the main feeders will be the deep inside, like the stronger one are deep inside, or the superficial one? And I remember that when I was reading about AVM resections and during my practice, that it's always recommended to do the resection in just circumferential manner, and just circumferential and looping manner. So would you recommend that fashion?
Yeah, you are correct. That's the traditional teaching, is that to go around the AVM in a circumferential. It's very important to avoid going down and digging yourself into a deeper hole. But more recently, some surgeons have proposed that in order to have better control of the deep feeders, might be reasonable to think about trying to go down the cone first. And then I mentioned, because again, it's something that you will might hear discussed at meetings. It's not something that I would recommend when you are starting, because it's much easier to deal with the small, deep feeding vessel after you have disconnected the bulk of the AVM than dealing with that deep feeder while the rest of the AVM is still connected. So you are correct. That's the traditional, and that's what I will recommend, and that's what I do. But you might hear, you might start hearing that some surgeons, and there might be some merit, might recommend to go down to the bottom first, because you still have the main flow from the larger feeders, and therefore the deep feeders, they are, you know, they're not quite as prominent as they might become if you have disconnected most of this arterial supply.
Okay, thank you, Professor.
Very good. Dr. Takashi, I'm glad to see you here. Did you also translate Dr. Lanzino into Japanese today? Dr. Tashi, are you there? Well, I guess we'll move on. I think we're also translated, Doc, into Japanese simultaneously, as well as Chinese. Okay, more questions or comments for Dr. Lanzino?
Excuse me.
Forward. Go ahead. Go ahead.
Good evening, Professor Lanzino. My name is Danu Rolian. I'm from Indonesia. It was an amazing lecture and remarkable, also lots of gems and diamonds, and very useful for us in practice daily. So my question would be, I'm interested in a way that you use the ICG to select the feeder in order to cut it down one by one. How would you give us explanation about how do we select using the ICG to hit which feeders first to cut using the ICG guidance? And then yes.
Oh, go ahead.
And the second question is, when we felt like we already cut down nearly all the feeders, and then how would you how do we select the draining veins, to which one do we cut the draining veins first in order to have a very good safe section without surprises like bleeding at the
Sure.
end of the section. Thank you very much, Professor.
Sure. So, you know, the ICG is useful if for the superficial parts of the AVM, because of course the ICG shows what the microscope would sees. It is, as I said, it's useful to have that additional feedback, but there is no question that you know, the main understanding and the strategy comes from studying the angiogram and then correlating the angiographic appearance with what you are seeing under the microscope. What I say for the ICG is that at the beginning, it might be not immediately clear what might be a feeder, what might be a draining vein in the tangle. And the ICG might be helpful because, of course, the feeder will feel a second before the vein. But that is not what I would base my decision. Of course, the decision and the strategy is based on the studying the angiogram and correlating the angiographic features to what you are seeing. Of course, it's nice to have, if you have the ICG available, it's easy. And it's nice to have that extra confirmation, but I will not use the ICG to necessarily guide my strategy. Now, ICG, that's different, for example, than spinal AVMs, where ICG is extremely helpful. And you can do the strategy that you were mentioning, where you can selectively, one after the other, take the feeders as they go into the AVM based on multiple ICG runs. But for a brain AVM, ICG is not necessary. Often it's not that helpful, but I think if you have it, it's nice to give you that additional feedback. And also at the end of the resection, if you have a superficial draining vein, you do an ICG run and you make sure that the veins, they fill properly in the venous phase and there is no indirect evidence of any early shunt. As far as your question about you are correct. You know, we always teach and say, okay, you do a resection of the AVM circumferentially, and you leave the draining vein at the end. But then when you go and do the surgery, you realize that usually there are accessory veins. I call them secondary veins. It's not only one vein. So I would say that usually the main draining vein, and again, based on the angiogram, is the one that needs to be left at the end of the resection once everything has been disconnected. As you proceed in your resection, it becomes often necessary to take some of those secondary veins that are not the main draining one. But after you have you do that after you have disconnected already parts of the AVM. Is usually those are superficial AVMs that have multiple draining vein, but there is usually one main one that is the one to leave for the end.
Thank you very much.
In that case, the strategy, of course, you try to preserve as much as possible, even the secondary veins, but then based on your surgical strategy, you have to make a decision in order to proceed with the resection. Of course, sequentially, you'll have to start disconnecting some of those secondary draining veins as well.
Thank you. Thank you, Professor.
Okay, more comments or questions from anyone in the panel? Or just to say hi to Dr. Lenzino? Ben, are you there? Would you like to comment? Oh, did you step away? Welcome, Ben. He may have stepped away. Okay.
Hi, John.
Hey, Harshad, how you doing? Welcome. Welcome.
I'm good, good. Welcome. Excellent lecture. Excellent lecture. Very good, very well presented, and all the tricks of the trade has been explained very well in AVM. The lecture is as good as you have given last time for AV fistula. Great learning, great learning. Rather than asking, it is a we have absorbed a lot. Wonderful job you have done. Wonderful.
Thanks.
And John always brings the talents all over the world and the stalwarts and make us learn more and more.
It's thanks to you, huh?
Yeah. And Jua is always there with us. Professor Jua is always bringing in from the China various things. Very learning phase. Hi, Professor.
It's Dr. Liao or Supin. Can you see how many people were, how big an audience we have now in China?
Ben, are you there? Or Dr. Liao? Any feedback on the Chinese audience that we're televising to? As typical, you had nothing's working, Dr. Lenzino. Some days things just don't go right.
We did, but we did it. We did it. It's like AVM surgery, you know, like you start with the plan, but then you need to adapt for as things change. But it's I apologize for the problem on my side. They put some new version of the software that is really, everything has become more difficult this week.
No, you won't be able to tell. We'll edit it, you won't even know it. So I'd like to thank you very much, and thanks Yuha for putting this together, and thanks Dr. Liao for translating, and Zubin for coming late, and thanks everybody for coming. And anytime you need to televise anything, Dr. Lenzino, let us know.
Thank you. Thanks.
Okay.
Thank you, everybody. Thank you, especially Giuseppe, for wonderful lecture.
Dr. Lenzino.
Thank you, Victor. Thank you.
Victor.
Thank you, Professor.